Right, quick one. Two words that sound the same but mean totally different things. Pharmacodynamics and pharmacokinetics. Let's start with pharmacodynamics. This is what the drug does to your body, the receptors it binds to, the effects it actually produces. So think effects. Now pharmacokinetics, this is the reverse. It's what your body does to the drug. Absorption, how it gets in, distribution, where it goes, metabolism, how it's broken down, and excretion, how it leaves, basically the drug's journey through you. Quick trick to keep them apart. PD, dynamics, think of the drug doing something once it's there. PK, kinetics, think of the drug moving through the body. Let's talk about baseline, because you need this before anything else makes sense. Baseline is simply the receptor's activity with no drug bound at all, and here's the bit that surprises people. The receptor is still slightly active on its own, even with nothing attached to it. Some receptors just sit on purely by chance at random. Now below baseline, this means that with a drug bound, activity actually drops lower than that natural drug-free level, so the receptor becomes less active than it would be if you just left it alone completely, untouched. This will become clearer on the next slide, where we go through the different types of drug effects on receptors, and specifically the inverse agonist effect. Okay, now that you understand baseline, let's go through the different types of drug effects one by one. First, a full agonist. This is a drug that binds the receptor and produces a full response. Simple as that, maximum effect. Next, a partial agonist. This drug also binds the receptor, but it only ever produces a partial response. Even if you give the highest possible dose, it never reaches that full effect. Then, an antagonist. This drug binds the receptor too, but it produces no response at all. It just sits there occupying the site, blocking anything else from binding. So activity stays exactly at baseline, nothing changes. Now, the inverse agonist, the one we set up last slide. Remember, baseline isn't zero. The receptor is still a little bit active on its own, even without any drug. An inverse agonist binds the receptor and produces a response below that baseline, meaning the receptor actually becomes less active than it would be if you left it alone completely, untouched. That's the key difference from an antagonist. An antagonist keeps activity at baseline, an inverse agonist pushes it below, and finally, an allosteric modulator. This one's a bit different from the rest because it doesn't even bind the same site as the drug or the natural ligand. It binds a separate site on the receptor, and instead of directly switching the receptor on or off, it changes how the receptor responds to whatever else is binding. It can make the response stronger, or it can make it weaker. So that's 5 ways a drug can interact with a single receptor: full response, partial response, no response, below baseline response, or simply adjusting the volume on however the receptor's already responding. Let's clear up another pair that gets mixed up constantly: potency and efficacy. Potency is simply how little of a drug you need to take for it to work. So a more potent drug does the job at a smaller dose. Efficacy is completely different. It's about how well the drug works at its very best, its maximum possible effect, regardless of how much you need to get there. Here's the example that makes it click. Fentanyl versus morphine. Fentanyl is far more potent than morphine, meaning you need a tiny fraction of the dose to get the same pain relief. But when it comes to efficacy, how much pain relief each drug can ultimately achieve at its maximum, they're actually the same. Neither one is better at killing pain than the other. Fentanyl just gets there with a much smaller amount. So remember, potency is about dose, efficacy is about ceiling. A drug can be incredibly potent and still have low efficacy, and a drug can need a huge dose but still have very high efficacy. They're two completely separate properties. Let's get straight into dose-response curves. Just the high yield points, no extra detail. There are 2 key curve types you need to be able to tell apart. First, the graded curve. This plots effect size against dose, but for one single person or one system. So as you increase the dose, you're watching how much stronger the effect gets in that one individual. This is what you'd use to compare how strong an effect is at different doses. It gives you a smooth, continuous curve. Then there's the quantile curve, and this is completely different. It's not about one person at all. This plots the percentage of a whole population that shows a particular effect against dose. So instead of asking how strong is the effect, you're asking what proportion of people got the effect at all, at each dose level. This is exactly what you'd use to work out how many people benefit from a drug, or how many experience side effects across a population. So the one-line distinction to remember: graded is one person, effect size; quantile is a whole population, percentage responding. Four terms. First, EC50 or ED50. This is the dose or concentration needed to get 50% of the maximum effect, and this is your potency measure. The lower that number, the more potent the drug, because it means you need less of it to get halfway to full effect. Next, Emax. This is the maximum possible effect a drug can produce, full stop, no matter how high you push the dose. This is your efficacy measure. The higher the Emax, the stronger the maximum benefit the drug can actually deliver. Then TD50, the dose that causes toxicity in 50% of people. This is purely a safety reference point, and you'll see exactly why it matters in the next term. And that's the therapeutic index, TI. You calculate it by dividing TD50 by ED50. A wider therapeutic index means a safer drug because there's a bigger gap between the dose that works and the dose that harms. Lithium is the classic example of a narrow therapeutic index, roughly around 2, which is exactly why lithium levels need regular blood monitoring. SSRIs, by contrast, have a wide therapeutic index, which is part of why they're considered much safer in overdose. Two types of antagonism, and the key exam skill here is reading what happens to the dose-response curve for each. Competitive antagonism. The curve shifts to the right, but it stays parallel to the original, and crucially, the Emax, the maximum effect, stays exactly the same. Why? Because a competitive antagonist is just competing with the agonist for the same binding site. Add enough extra agonist, and it'll outcompete the antagonist and still reach that same maximum effect. You've just had to push the dose higher to get there. So the good news here, yes, you can overcome it simply by adding more agonist. Non-competitive antagonism is a different story. Here the curve shifts right, but the Emax actually drops. The maximum effect you can achieve gets lower, no matter how much agonist you add. This happens because a non-competitive antagonist isn't fighting for the same site, it's either binding somewhere else entirely, or binding irreversibly, so it permanently takes receptors out of action. And that means no amount of extra agonist can fix it. The ceiling itself has been lowered, so the one-line way to remember this: competitive, you can push through with more drug. Non-competitive, you can't because the maximum effect itself has changed. We've talked about how drugs affect receptors. Now let's look at the different types of receptors themselves. And the first big split you need to know is ionotropic versus metabotropic. Ionotropic receptors are the simplest to picture. The receptor itself is the ion channel, so when the drug binds, it directly opens that channel and ions flow straight through. Because there's no middleman, this is fast. We're talking milliseconds. The GABA receptor is the one to know here, and it's exactly where benzodiazepines do their work. Metabotropic receptors work completely differently. Binding here doesn't open a channel directly. Instead, it triggers a chain of internal messengers inside the cell, which then go on to produce the effect. Because there's this extra step, it's slower. Seconds rather than milliseconds. The D2 receptor is the big one here, and it's where most antipsychotics act. So the one-line way to remember this: ionotropic is fast and direct, metabotropic is slower and indirect through second messengers. Let's go a level deeper now, and actually look at how an ionotropic receptor works, step by step. These receptors are built from several protein subunits, usually 4 or 5 of them, that come together and form a ring, with a pore running straight through the middle of the cell membrane. So structurally, the receptor and the channel are literally the same physical structure. That's what makes ionotropic receptors so fast. Now on this structure, there are two different types of binding sites you need to know. First, the orthosteric site. This is where the natural neurotransmitter binds, or where a true agonist binds. When something binds here, it physically twists the subunits, and that twisting motion is what opens the pore. That's called gating. Then there's the allosteric site, and this is a completely separate location on the receptor. Drugs that bind here don't open the pore by themselves. What they do instead is change how easily the pore opens when the natural neurotransmitter binds the orthosteric site. This is exactly the distinction we just covered. Benzodiazepines bind the allosteric site on GABA-A, and they only work when GABA is also present, binding the orthosteric site at the same time. Bind both, and the channel opens much more easily than with GABA alone. Once the pore does open, ions simply flow down their concentration gradient. So chloride flows in for GABAA, sodium and calcium flow in for NMDA, and because this is just ions physically moving through an open pore, with no chemical cascade involved, the whole thing happens in milliseconds. That's the defining feature of every ionotropic receptor. One more thing worth knowing, these receptors don't stay open forever. With continued exposure to a drug, the receptor can enter a desensitized state where it stops responding even though the drug is still bound. That's part of the mechanism behind tolerance with some of these drugs. Every ionotropic receptor is built the same basic way. Several protein pieces called subunits join together in a ring with a pore running through the middle. Take GABAA, short for gamma-aminobutyric acid type A, 5 subunits. GABA binds one spot, but benzodiazepines bind somewhere completely different on the same receptor, which is why they can't do anything without GABA already there. NMDA, N-methyl-D-aspartate, needs 2 separate things bound at once, glycine and glutamate, both together before it opens. AMPA is simpler, it just needs glutamate, no second molecule required, and it's very fast. Nicotinic ARC receptors, the nicotinic acetylcholine receptors, are also 5 subunits. Nicotine binds directly and opens them on its own, no coagonist needed. 5-HT3, short for 5-hydroxytryptamine type 3, is built the same way as all these others, just for serotonin instead, and it's worth remembering because it's the only serotonin receptor that works this fast, ionotropic way. Every other serotonin receptor is the slower metabotropic type, and glycine receptors use the same basic pore structure too, but they're inhibitory, and they mostly work down in the spinal cord and brainstem rather than higher up in the brain, so different names, different jobs, but the same underlying mechanism throughout. Something binds, the pore opens, ions flow straight through, and it all happens in milliseconds. Right, let's now attach actual drugs to the ionotropic receptors we've covered, and this list is shorter than you'd think, because most psychiatric drugs don't actually work this way. Benzodiazepines are the obvious one. Diazepam, lorazepam, alprazolam, clonazepam, all positive allosteric modulators at GABA-A, working at that separate site from GABA itself. Barbiturates work similarly at low doses, but at higher doses they can act more like direct agonists, which is exactly why they're so much more dangerous in overdose, and why they're barely used anymore. Alcohol also enhances GABA-A, which is part of why it's sedating and why withdrawal can be dangerous. The brain adapts to that constant GABA enhancement. Ketamine and esketamine are the standout ionotropic antidepressants. They block NMDA receptors, and this is actually the core mechanism behind their use in treatment-resistant depression. Memantine also blocks NMDA, but that's mainly used in Alzheimer's, not primary psychiatric prescribing. Mirtazapine has a secondary action blocking 5-HT3. That's part of why it doesn't tend to cause the nausea you sometimes see with other antidepressants. And varenicline is a partial agonist at nicotinic receptors, specifically the alpha-4-beta2 subtype. That's its whole mechanism for smoking cessation. Let's focus now and look at how a metabotropic receptor actually works, step by step. These receptors are a single protein that crosses the membrane 7 times, and on the inside they're coupled to a separate protein called a G protein. They are not the channel themselves. There's an orthosteric site, where the natural neurotransmitter or a true agonist binds. That binding causes the receptor to physically change shape, and that shape change is what activates the G protein sitting underneath it. There's also an allosteric site, a separate spot where modulators bind. These don't activate the receptor on their own, they just change how easily it activates when the natural neurotransmitter is also bound. Now let's actually open up the G protein itself, because it's not one single piece. It's made of 3 subunits, called alpha, beta, and gamma. In its resting state, the alpha subunit is holding onto a molecule called GDP. But when the receptor gets activated, it forces the alpha subunit to swap that GDP for GTP. And that swap is the trigger. Once that happens, the alpha subunit physically separates from the beta-gamma pair, and now you've got 2 independent pieces, alpha on its own and beta-gamma together, and both of them can go off and trigger their own downstream effects. Here's the important part. There are 3 main types of alpha subunit, and each one does something different. G stimulates the production of cyclic AMP. The beta-adrenergic receptor works through Gs. GI does the opposite. It inhibits cyclic AMP production. The D2 receptor, which is central to antipsychotic mechanisms, works through GI, and GQ activates a different pathway entirely, involving IP3 and DAG. Alpha-1 adrenergic receptors and 5-HT2A both work through GQ. So all of this, the second messengers, the enzyme activation, the eventual change inside the cell, that's what we mean by the downstream effect. it's simply the final result further along the signaling chain from that original binding event at the receptor. The metabotropic receptors that actually come up again and again in psychiatry. Dopamine splits into two families, D1 and D5 are Gs coupled. No major clinical drug targets these directly. D2, D3 and D4 are GI coupled, and D2 is the big one, main antipsychotic target. Serotonin, 5-HT1A is GI, buspirone acts here as a partial agonist, 5-HT2A is GQ. Atypical antipsychotics block this, but so do trazodone and mirtazapine, which is largely why they're sedating. 5-HT2C is also GQ, and mirtazapine blocks this one too. That's part of why it increases appetite and weight. Adrenergic, alpha-2 is GI, and this is mirtazapine's core mechanism, along with clonidine. Beta receptors are Gs. Muscarinic, M1 is GQ, and this is where the tricyclics amitriptyline and clomipramine cause their classic anticholinergic side effects. Histamine, H1 is GQ, and mirtazapine and the tricyclics block this too, driving sedation and weight gain. Opioids, mu, kappa, delta, all GI. Morphine works mainly at mu. GABA B is GI, that's baclofen, and melatonin receptors MT1 and MT2 are GI, that's agomelatine's mechanism. So notice how many antidepressants actually work through multiple receptors at once. Mirtazapine alone hits alpha-2, 5-HT2A, 5-HT2C, and H1. That's exactly why its side effect and efficacy profile looks so different from an SSRI, which is comparatively more selective. Let's close out with a full summary, starting with everything that acts on ligand-gated channels directly. Now with the drug class labeled 2. Benzodiazepines and Z drugs both work on GABA A chloride channel just with different subunit selectivity. Ketamine and esketamine, classed as NMDA antagonists used as antidepressants, block NMDA, and memantine, an antidementia drug, blocks that same receptor uncompetitively. Mirtazapine, a NASA, has a secondary block on 5-HT3. And galantamine, a cholinesterase inhibitor, also positively modulates nicotinic receptors as a secondary action. Next, everything that works through G-protein coupled receptors with the class named alongside each. Typical antipsychotics block D2 directly. Atypical antipsychotics block D2 and 5-HT2A together. Aripiprazole, still classed as an atypical antipsychotic, is a partial agonist at D2 rather than a full blocker. Clozapine, also an atypical, hits the widest spread. D2, 5-HT2A, histamine, muscarinic and alpha-1, buspirone and azaparone anxiolytic is a partial agonist at 5-HT1A. Trazodone, classed as a SARI, blocks 5-HT2A. Mirtazapine, a NASA, blocks alpha-2, 5-HT2A, 5-HT2C and H1. Agomelatine, a melatonergic antidepressant, is an agonist at the melatonin receptors. Guanfacine and clonidine, alpha-2 agonists, are used for ADHD. Opioid analgesics act mainly at mu, and baclofen, a muscle relaxant, is an agonist at GABAB. And finally, everything that doesn't bind a receptor at all, with the class named for each. SSRIs block SERT, SNRIs block SERT and NET. TCAs do the same but also directly block M1, H1 and alpha-1. Atomoxetine, our NET-selective ADHD drug, blocks NET alone. Methylphenidate, a stimulant, blocks DAT and NET. Damphetamine, also a stimulant, goes further, hitting VMAT2 and reversing the transporters. MAOIs block the enzyme that breaks down monoamines. The cholinesterase inhibitors donepezil, rivastigmine and galantamine all raise acetylcholine for dementia by blocking that enzyme, and the exceptions, our anticonvulsant mood stabilizers valproate, carbamazepine and lamotrigine, work on voltage-gated sodium channels. Lithium, also a mood stabilizer, works entirely inside the cell, and our anti-amyloid monoclonal antibodies lecanemab and donanemab clear amyloid plaques directly. No receptor, transporter or enzyme involved at all. So that's the complete picture. Every major psychiatric drug class sorted by how it actually works. Ligand-gated channels, G-protein coupled receptors, transporters, enzymes, and that small handful of exceptions that don't fit anywhere else. Once you can sort any drug into one of these boxes, you're not just memorizing facts anymore, you're predicting behavior. That's the difference between cramming for an exam and actually understanding pharmacology. That's it for this series. Thank you for learning with me, and I'll see you in the next one.